My name is Dr. Reed Tuckson, one of the co-founders of the Black Coalition Against COVID and a frequent partner with our colleagues at blackdoctor.org. Welcome to this episode of called COVID 2.0, from pandemic to endemic. Let me just give you a sense of what these words mean. So endemic describes how far epidemic describes how far a specific outbreak of a disease has spread. It references an unexpected increase in the number of disease cases in a specific geographical area. That's sort of what epidemics are about, describing how far a specific outbreak of a disease has spread. And endemic, E-N-D-E-M-I-C, refers to the constant presence of a disease in a geographic population. And so in many ways, we are now in this new normal, this endemic state, where we have to now learn to deal with and protect our health, our loved ones, and the health of the communities in which we live. This is a very important moment in our contemporary history, and it's a very important moment to get at these issues of how can we protect and advance our health while we are living with an endemic disease called COVID. This event is sponsored by BIO, the world's largest biotech trade association, the field where breakthroughs begin, and we thank them for their sponsorship. Well, I'm excited about our panelists with us today. Let me begin with Dr. Pragna Patel. She is a physician and an epidemiologist, someone who studies the trends in disease manifestations in populations. She is the chief medical officer of the CDC's Coronavirus and Other Respiratory Viruses Division. She has a specialized expertise not only in clinical care and public health, but also in research. I'm very pleased that Dr. Eric Griggs is with us. He has distinguished himself as the Assistant Vice President of Community Affairs at Access Health, Louisiana. He is an adjunct assistant professor at the Tulane School of Public Health and Tropical Medicine, also at the LSU School of Medicine, and if that weren't enough work, also he is at the Xavier University College of Pharmacy. I am particularly pleased with his work as the national chair of the COVID-19 task force for the 100 Black Men of America. Dr. Chiji Oda Bennett is the senior director for clinical development of the company called Novavax. There, he is responsible for leading clinical development programs for their COVID variant vaccines and for COVID vaccines in immunocompromised populations. He has a great expertise in general medical practice, global public health, and clinical research. And we are very also pleased to bring Dr. James Mance. Dr. James Mancy is the Vice President for Medical Affairs of US at Moderna Incorporated. Over more than 25 years of experience in medical affairs, he's been involved with the development and introduction of over 8 different novel vaccines. His work is focused on addressing knowledge and data gaps towards supporting evidence-based clinical and public health decision-making. There's probably no more important area that is involved in medicine today, and one of the main reasons why we do these shows for you, our audience, is to in fact support evidence-based clinical and public health decision-making, making health choices based on facts, not rumors and innuendo, and definitely not based on misinformation designed to harm our people. Well, let's get started with Dr. Patel. Dr. Patel, you know, as you go around this country, it seems that the general public has sort of moved on from COVID. But as I look at the infection numbers, they're still here and they're growing. What can you tell us about the current infection rate today versus when we started this back in 2020? What's the difference? What's going on?
Well, thanks. It's such a pleasure to be here and talk to you about COVID. We currently are seeing hospitalizations and death from COVID-19 increasing, and it's concerning. Although these parameters remain low compared to previous times in the pandemic, we're in a much better place now because, we have the tools that we need to help mitigate this pandemic. We've got testing, we've got vaccines, we've got treatments. There's some immunity in the population. COVID-19, though, is still a public health threat. And we do anticipate that we'll see a surge later on this fall. And so it's really important for us to remain vigilant. I will say that we've moved to, using home-based tests, and so CDC is not getting the same type of testing data that we used to, but we have a number of different parameters that we use to help us track what's going on with this pandemic. We look at positive test results from PCR tests that are done in laboratories and that are reported to us. We look
I'm
at
sorry, the PCR test. What does that mean?
It's basically, it means polymerase chain reaction test, but it's basically a test that looks for the virus that's incredibly sensitive. Mostly it's done in doctors' offices and in hospitals.
That's different than the one that we buy in the pharmacy.
It's different than the antigen test that you get in the pharmacy. So the PCR test is a bit more sensitive. So if you have COVID-19, it's more likely to pick it up. But the antigen tests are still very good. As I was saying, we also use wastewater surveillance to help us detect, cases that may be on the rise, early detection. We look at emergency department visits, we look at hospitalizations, and then we also are in constant contact with our public health departments to get a sense of what they might be seeing. So all of this put together gives us an idea of what's going on with the pandemic currently.
And when you're doing, by the way, I think a lot of people in the audience will be fascinated to know that modern public health takes advantage of wastewater, something we would never think of, and that actually we can detect the virus in wastewater in a meaningful way to tell us about trends in infection. That's amazing, isn't it?
Yeah, it's sort of a new approach. I mean, it does have its limitations, but it has been a useful complement to the other surveillance systems that we have that help us understand what's going on with COVID.
So as you are doing all the surveillance, let's talk about variants. Now, let's remind our audience what
Mhm.
viruses do. That's their job, is to change what they are into new forms so that they can continue to be successful. Unfortunately, they try to be successful at killing us. So these are guided missiles with their own intelligence that tries to change its format so that it can evade our defenses. What are we seeing now about the variants?
So I agree with you completely. All viruses, including SARS-CoV-2, change over time, and they're going to mutate to for their own survival. And so right now, the dominant variant in the U.S. is called XBB. It's a sublineage of Omicron. There's another variant called EG.5. And together, these two variants account for about 95% of the circulating virus variants in the US. Luckily, the symptoms seem to be similar to previous Omicron lineages, so that's good news. We've also been tracking a new variant that you may have heard of, BA.2.86. It doesn't appear to be rapidly increasing or driving increases in infections or hospitalizations in the US. And there seems to be low levels of community transmission of this variant. And we know this because we don't have known links for people who are infected with BA.2.86 to other infected individuals. They haven't recently traveled to an area with known cases of BA.2.86. And so we're keeping an eye on it, we're monitoring it, but we're not expecting that it will take off, which is good news.
Well, that is good news, but let me throw in some bad news and see if
Okay.
you agree. I don't want to celebrate bad news. But in addition to this COVID-19 new variants, which are still important and serious, but hopefully, fingers crossed, they won't be as bad in terms of creating as much death or hospitalization as the previous strains. It comes in combination with the RSV, or the respiratory syncytial virus, and the flu season. We now have three things hitting us all at once. I
Mhm.
think that's not good news.
It is not good news, but let's look at the silver lining. For the first time, we actually have preventative tools for each of those viruses. We now have a vaccine for RSV. We have a yearly vaccine for influenza, and we have this updated vaccine for COVID-19. So we're in a very good place to combat all three viruses. It's an exciting time for preventing severe disease due to these viruses. And CDC wants to do what we can to ensure that we get these tools to the people who need them the most.
Now, one of the questions that I get a lot, and I didn't know the answer. I waited before I answered any of these questions until I talked to you tonight.
Okay.
Should I get all three of the vaccines, the one for the RSV, respiratory syncytial virus, which, by the way, is very similar in terms of its symptoms to the flu and very similar to COVID? Should
Mhm.
I get the RSV and my annual flu? Because we know everybody is good about getting their annual flu shots, I'm sure. And the COVID one. Can you do all three at the same time, or do I need to stretch them out?
You can do them all at the same time. We do recommend maybe getting them in different sites. So COVID in one arm, flu in the other arm. I will say that RSV is recommended for people who are age 60 and older, but we're asking patients to have a conversation with their clinicians about whether that particular vaccine is right for them. It's a new vaccine. We didn't give a population level recommendation for this vaccine because it wasn't clear that there was a huge impact by having everyone vaccinated for it. But certain individuals could really benefit from it.
Great. Now let's cone right in on the COVID vaccine, and we'll get to our colleagues from who are in the business of actually producing and marketing and selling these important vaccines. But let's just get right to with you. Um,
Mhm.
what is the recommendation right now for the people that are listening to this audience, some of whom are very old, some of whom have pre-existing conditions, some of whom are very, very healthy? What's the recommendation about getting the COVID-19 vaccine, the new one, and not only if who should get it, but when?
So, CDC's Advisory Committee on Immunization Practices voted on September 12th, last week, to recommend the updated COVID-19 vaccine for everyone 6 months and older. And the CDC director endorsed this recommendation. And so we think that you should get this vaccine. It's a great vaccine because we're calling it an updated vaccine because it's based on the XBB 1.5 lineage. And so we anticipate that this vaccine will be better at fighting currently circulating variants because XBB lineages account for a considerable number of cases of COVID in the US right now. And then early research data from multiple labs are very reassuring because they show that existing antibodies from people who were infected with XBB work against the new BA.2.86 variant. And these data are encouraging because what it may mean is that the effectiveness of the updated COVID-19 vaccine, which is based on XBB and produces similar antibodies to people who are infected with the XBB vaccine, it would offer protection against BA.2.86. And an important goal of vaccination is to broaden somebody's immunity, which is why we updated the formulation. Even if the vaccine formulation does not perfectly match with the variants that are circulating currently, we still think that there will be protection. And we think that this protection will be afforded throughout the year. And so we're asking folks to take this important action, stay up to date with your COVID-19 vaccines, protect yourself because your immunity will wane since the last dose that you got, and new variants are going to emerge. The
Now,
virus will continue to mutate.
now I really heard you, and you were very clear about the CDC director. And by the way,
Mhm.
Dr. Mandy Cohen is doing a terrific job, and she deserves all of our support as she tries to help make sure that the agency becomes the agency that we all want it to be, and all the hardworking people like you who are giving their lives to this work. Thank you, by the way, for your service. I didn't say that at the beginning. But you were very clear that she has signed off on the recommendation that everybody should go ahead and get themselves vaccinated.
Mhm.
There are some special groups of people that we might want to be particularly attentive to. Can you describe within the whole population getting it, who are the ones that should make doggone sure they get it?
Well, there are a few populations that are at risk for severe COVID-19. When I say that, I mean hospitalization and death. And so those people really absolutely should get it. These are people who are persons aged 65 and older, persons who have more than one underlying condition, a chronic condition like diabetes, obesity, cardiovascular disease, especially persons who have immunocompromising conditions or are on medications that render them immunocompromised or weaken their immune system. And then persons who are either not vaccinated or who have not been up to date with their vaccines, because we know that that immunity does wane.
I'm going to turn in a second here to Dr. Griggs to start to talk a little bit about how we convince people to be able to want to take the vaccine. But you mentioned, Dr. Patel, something called the ACIP. I am aware that there are two federal agencies of scientists who are involved in the process of final approval and recommendation of vaccines. One of them groups is in the FDA, the Drug Administration, and one is in the CDC. Can you mention again so that the public understands what are these mechanisms, and are there people of color on these committees looking out to make sure that the Black community can feel confident that we are represented in these back rooms?
Yes, absolutely. So FDA obviously is the regulatory body. So the companies have to submit an application for FDA in the same way that they do for medications, where they show data to show that this product is safe and effective. So safety is as equally important as effectiveness. Once FDA approves a product like a vaccine, CDC has an advisory committee that will come together and review a lot of data. We don't just count on the company's data. We review studies that have been done. Academic centers provide data. We have academic partners on those panels. We have CDC folks on those panels, and we do have company representatives on those panels. And we, try to really go through all the aspects of the vaccine that we want to consider. For example, what were the side effects? What are the adverse events that we might expect to see? Are there certain populations that we would be concerned about in giving this vaccine? Who would benefit the most? And once all of that is reviewed, the committee makes a recommendation, and then the CDC director either accepts it or does not accept it.
Great. Well, listen, this is very important, and I just want to really emphasize this issue. And Dr. Griggs, by the way, before I turn to you, Dr. Griggs, let me say to the audience, if you have school-age children in your home watching this, I urge, especially if you have young men in your audience, and if they have any interest in science, bring them in front of the screen and make sure that you see these two physicians of color who are preeminent scientists, very smart clinicians in this country. If you ever wanted to make sure you had a role model for your young Black men, you've got two of them on the screen right now, and you'll never get an easier way for your kids to get excited about science and excited about health. So, Dr. Griggs, I think this issue of how do we get the Black community to become more confident that they can trust these vaccines that are coming out of the pharmaceutical industry and that are being regulated by government enterprises. And I wanted to make that extra effort, Dr. Griggs, that we are represented on these committees and that our scientists are involved in the process. But what is your take on what have we gone through, and what has been the challenge of getting more people, and in your case, 100 Black men, more men of color to take the vaccine?
Boy, you triple whammied me on that one. Yes, yes, and yes. The thing is, you have to be honest and confront, but more importantly, respect the issue at hand, respect the history of distrust, respect the reasons of distrust, but most importantly, respect the audience. When you're dealing with people that don't necessarily trust or believe in the vaccines, instead of walking away or beginning a confrontational conversation, you take time, respect, and listen to them. That's the biggest thing that I found over the last 4 years is just people want to be heard. And they want to know. A lot of times what we will accept generationally as fact turns out indeed to be a myth. One of the first things that comes up in the Black community is the Tuskegee experiment. And everyone's like, oh no, they're going to inject syphilis into your arm. I'm like, no, it just doesn't work that way. That's not the way it worked. The travesty and the seriousness of the matter of the Tuskegee experiment is different than that, but you have to explain it. What the travesty wasn't that they injected it into people's arms. The travesty is that they weren't treated. But then you talk about it, have open, honest discussions, respecting everyone's opinion, and then countering it slowly, albeit slowly for some folks, with facts. And what happens is, if you take the patient goal of trying to educate your community, you end up with a legion of advocates and champions as opposed to an army of adversaries.
I'm so glad that you mentioned the Tuskegee experience. And let's just be very clear for every member in our audience. The Tuskegee, as you said, Dr. Griggs, the Tuskegee insult was that people with a disease, Black men with a disease, were denied treatment that was available for their disease, left to suffer and die untreated. How in the world can people in our community in 2023 say, because of Tuskegee, I'm not going to take the vaccine? In other words, I'm going to deliberately deny myself the treatment that would save my life just to show how angry I am about the fact that Black men were denied treatment for their disease. It is absolutely nonsensical that Tuskegee would be used as a reason for not taking their vaccine.
And surprisingly, Dr. Tuckson, that is one of the first things that comes out of people's mouths. And what happens is exactly what our audience and our panel just witnessed, is that sometimes you have to cut the MD and the DR off your name and introduce them to Eric. And the same little guy that grew up in the neighborhood that would argue with you in second and third grade would argue with you now, but that makes absolutely no sense. You respect them, you meet them where they are, and then with the goal of building it up by introducing and teaching them the value of science.
Well, I have really appreciated the work you've done, and I really appreciate what 100 Black Men have done. You've done a PSA that I thought was pretty terrific. And can we, let me go to the production trailer. Can we put that PSA up? Is it available?
Strong, well enough to sing my song. Raspy voice, persistent cough, everything was feeling off. I couldn't breathe, my lungs were burning, my brain was foggy, my stomach churning. I'd had COVID a few months back. Shouldn't I be back on track? Then I learned about long COVID can really take a toll. How can I take control?
When coronavirus attacks your system, the lungs and diaphragm can be primary victims.
Inflammation of the vocal cords makes your voice sound hoarse, as you've observed.
And the vagus nerve affects your breathing. Irritation causes coughs and wheezing.
The good news is we have the information
to get ahead of this COVID situation.
My treatment plan involves self-care, staying boosted, I'm aware. Healthy eating, exercise, and rest. Meditation to relieve my stress. In just a bit, I was back to singing. So enjoy this joyful noise we're bringing. Move along, move along, move along. So move along, move along, move along, move along, move along.
Now, that was pretty terrific. But, you know, as I was watching it, Eric, as I was watching it, it took me back to a very prominent African-American woman singer who in the middle of COVID decided to spread this crazy nonsensical thought that her cousin in Trinidad who was about to get married got vaccinated and it made his testicles swell up and blah, 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 all of which, of course, was absolute total nonsense. And unfortunately, caused a lot of Black women to not get vaccinated and may have cost people their health and their lives. This singer that you have chosen is very different. How do you see the work that you're doing and the work of 100 Black men being able to move us forward to be able to try to get our community appropriately immunized so that we can save Black life? And the slogan I always use, Eric, is that if Black lives matter, and they do, they have to matter to us first.
First and two, absolutely. Sometimes, as we know in the Black community, we got to take people to church. The church has been the pillar of the community, and when you do it in song, Tanya Boyd Cannon, living in New Orleans, we're blessed with a number of talented artists. Tanya Boyd Cannon was a contestant on The Voice. She's a personal friend. She worked with myself, Dr. Mark Allen Derry, who's an infectious disease doctor and epidemiologist, and we happen to be the voice of COVID for the region over the last 3 years. And again, when the misinformation comes out, we counter it with information and reaching people in places, putting on a choir robe. I hadn't put on a choir robe since I originally tried to grow hair from the head that I have now. So that was very, very familiar to me. Putting myself in a cartoon in a choir robe, it disarms people. If a high-functioning society is child-centered, adult-governed, and elderly ruled, were someone's child to walk into the room right now, all of our eyes would turn to the child in the background to make sure they're okay, and we would closely watch, Dr. Tuckson, what you would be saying to that child. Well, it's the same thing. By doing it in cartoon form, it disarms and it provides a veil of security for adults to actually mask their fears and hide their own misgivings about anything that might be going on with education. They nod their heads like the kids, like they know when they're learning themselves. So, it's again, you confront it head on and you find a disarming way and a non-threatening way to counteract the misinformation with true science.
By the way, you mentioned the kids in the audience. Dr. Patel, let me go back and make sure I've got this right. That this vaccine you're recommending, according to the external advisory committees to the CDC and the FDA, outside scientists coming to bring their intelligence along with government scientists, I think down from 6 months and older. Did I have that right?
Yes, you did. Excuse me. We are recommending it for 6 and older.
All right. Dr. Griggs, the last question, I'm going to turn to my other panelists in a second, but your video emphasized long COVID. I don't think that people fully appreciate the risks of regular COVID and what that can mean for so many people. Is long COVID just an interesting observation that a few people happen to get?
Now, long COVID, first of all, there is, this conversation is rooted in health literacy. There was a misconception in the community for a while that COVID, it's just like the flu. Oh, it's just like the cold. No, COVID affects every blood vessel in your entire body, every single blood vessel, which is why we see the incidence of cardiac events going up. We see the incidence of all chronic diseases going up. Why? Because all the organs need blood and the blood vessels are damaged. When they take time to heal, when there's scar tissue, they might not function as they did before. So though you might have the mild symptoms, and maybe we need to have a discussion about the difference between a disease and symptomology and what symptoms are, but because I might mask myself as COVID like something as benign as hay fever or allergies, I'm damaging blood vessels and there'll be long-lasting effects. So it's not something that you want to contract. So you have to vaccinate, do everything you can to protect yourselves if you don't want long COVID. If you can remember, as beautiful as her voice was, man, she couldn't even sing. She lost her solo spot in the choir. Now, what soloist wants to do that in a church?
All right. All right. Well, very good. Dr. Bennett, I like science, and we want science to be fun. We want the audience to like science too, because our whole lives are based now on more and more on science and science and science. So we have these vaccines, and there are different vaccine technologies. I understand that there's a protein vaccine, and then there's the mRNA vaccine. Can you just give us a little cheat sheet that brings us up to date on the two different strategies for creating these vaccines?
Oh, absolutely. Thank you, Dr. Toxin, and just a pleasure being here as well, everybody. So let's sort of back up a bit. The whole aim of the vaccine is to get an antigen presented to your immune system. And there are ways the vaccines have been able to achieve this. And that's what we have as the platforms of use. So I'll start with the mRNA vaccine platform. One of the big misconceptions is that this came up out of nowhere. It's been on since the 60s. We knew how to get mRNA into people's cells in the 70s. What this vaccine does is it codes a strand of the spike protein for COVID, takes a strand of that as an mRNA, attaches it to a lipid nanoparticle, and sends that into the human cell as a vaccine. Now, when you get the mRNA vaccine, you've received essentially a code, a written code that your cell now recognizes and produces in your own cells the spike proteins. The whole essence being that we can provide your immune system a sort of preview of what this disease will look like in a mild form. So you're getting...
Before you go further, I want to just stop right on that point and say, I see this vaccine going into the cell, but please remind us that it does not go further.
That's correct.
Where am I headed? Tell me where I'm headed.
Big people turn into monkeys, and we'll change your DNA. No, so the mRNA gets into the cell cytoplasm and gets read in the cytoplasm, doesn't go beyond that, doesn't get into the nucleus.
Does not go into the nucleus.
Does not get into where the DNA is. It does not go to DNA. We can't change who you are. If I could, I would lose 40 pounds with an mRNA vaccine. And so here we are with the misconception. But I think you raised a good point of the toxin. The site at which this thing happens is important to make the distinction. There is no interface between this vaccine's mRNA strand and the cell's DNA in the cell's nucleus.
So I interrupted you were going a lovely story. So now we've got it in the cell, but not in the nucleus. Now what happens?
Correct. Now your cell reads the mRNA strands and produces that same spike protein that the mRNA codes for on your own cells. And now your body will see the spike protein and mount an immune response to it. And that's how the mRNA vaccine platform works. Again, there is no viral component. You're not getting the virus. So the risk of getting a disease is pretty much absent when you get a strand of mRNA that has been coded from the spike protein of the virus. Now, pivoting to what my company does with the vaccine protein recombinant proteins. It's somewhat similar. The final aim is to get your body to see the spike protein. So this is what we do. We take the DNA of the spike protein and attach it to a plasmid. It's like a little curvature of DNA, and we stick in the spike protein DNA now. Catch the difference. The DNA going from the spike protein of the virus into a plasmid. When we do that, then we introduce it into what's called a baculovirus. Think of this as a needle. We need something to take this DNA plasmid, this recombinant DNA particle, recombinant protein, sorry, I've taken DNA, a recombinant protein particle, and send it into the moth cells. We use the SF9 moth cells in Novavax to create the spike protein. So let me sort of go back a little bit. We take a strand of protein from the spike protein, a strand of that coding material for the spike protein, attach it to a recombinant particle, and we put that in a baculovirus. The baculovirus carrying that strand enters an SF9 cell. That SF9 cell produces now on its surface. So the baculovirus goes into the cell, and then the cell on its surface produces the full length protein of the spike for the coronavirus, the SARS-CoV-2. And we harvest that full length protein and attach it to SB80. It's a solid-propionyl thing that allows us get access into the cell. And so we can have a lipid affinity molecule that allows us introduce the protein particles into the human body. So what we've done again is we've taken the protein. So with the protein vaccine, we take the full-length protein, now not the mRNA, but the full-length protein, we attach it to a nanoparticle, create a trimer of some sort, bunch them together, and in our case, we have an adjuvant, which we combine together to form a vaccine, and we introduce into the human body the full-length protein.
So we really now have all these little taxi cabs, and we sort of put the information that we need, gets a ride on the taxi cab. The taxi cab has got a great Waze system or Google system that lets it know where it's got to go, and it gets right into where it goes. Now, Dr. Bennett, I know you're a good scientist, and I know you believe in the things that you are doing, and I know that Novavax is a great company. But how do I know that everything you just said is safe and that it works? I mean, I know you look credible now. I'm not going to say you do, but I need to know that I'm not gambling here. How do I know this thing works?
So I think part of this is going to lean on what Dr. Griggs and Dr. Patel have spoken about. I think it's, finding comfort and faith in the integrity of the data. We are not here cooking things up. We are actually going to the agencies and providing them with really robust data to say, hey, this is the immune response, this is the efficacy, the safety that we see with these vaccines. And I think to Dr. Griggs' point as well, it's just having that diversity on the front line, seeing people who look like you at these conversations, that table. I remember when I went to get my vaccine. So I live in Baltimore, Maryland, and I went to get my vaccine downtown, and the lady who was sort of the chaperone for getting the vaccines, was in the heat of the pandemic, was a woman who looked like me. And she leaned in and told me, should I get the vaccine? And I'm like, wait a minute, you work here. But she hadn't gotten it. And I told her, yes, you can. I helped make it. And she said, okay, if you say so. But it was important to her that somebody that looked like her had seen how this thing was actually made. I think part of that trust, both community and science, it has to come together to tell one cohesive story of how we can put our faith in the people who have done this work.
And let's not also forget the fantastic young Black woman scientists who helped invent as well. And so we are all in this. Dr. Mancy, this is not experimental, is it? Are we beyond experimental here?
Oh, good evening, Dr. Texan. Thank you so much. I have to say before I begin, I'm truly honored and privileged to be part of this panel. So thank you so much for the invitation. No, these are not experimental vaccines, and I'll lean on what at the beginning of what Dr. Patel said. This pandemic afforded us a renaissance in vaccinology with this mRNA platform. And it showed us that we can go quickly in developing a vaccine, bringing it into humans. In fact, from the vaccine concept at the beginning of the pandemic to the first in-human trials was 60 days. 60 days. That's remarkable. And then when you think about it now, from that VRBPAC meeting that Dr. Patel was mentioning at the midpoint in June of this year, where the FDA said, manufacturers, this is what we want in the vaccine for the fall. That was 8 to 10 weeks later, tens of millions of doses are in the system. And in fact, we're shipped as of last week in pharmacies and healthcare providers. But your question is this an experimental vaccine? No, we've updated this vaccine. This vaccine has been studied in phase 3 trials in tens of thousands of individuals.
I'm sorry, what's a phase 3 trial?
Oh, phase 3 trial is the last phase of a trial when in clinical research, when we're looking at the safety, the immunogenicity, the efficacy. Does this vaccine work in a large, broad sample of the population across different individuals so that we have a robust data set on which to evaluate and assess both the safety, the immunogenicity, and really have a a sample that allows us to get to statistical significance and really say, hey, does this vaccine work? Yeah, in fact, this vaccine does work. We've looked at it in 30,000 plus subjects. Is it safe? Absolutely. We've looked at it and we evaluated the safety and tolerability of the vaccine. So we're not at that experimental stage anymore. In fact, the FDA approval is a full licensure. So no, it's not experimental, and I think it stands on a robust body of evidence.
Let's talk a little bit about this speed. This is one of the things that has come that's an incredible scientific achievements, but it's also one that when we try to convince people of safety and effectiveness, it also comes back to hurt us. And that is, how do you do it so fast? And that somehow or another speed is then viewed as being a negative. Talk to us a little bit about why we should not only be not concerned about the fact that you were able to, companies like yours are able to do this so rapidly, but in fact, it is one of the triumphs of the human genius that we can do this so rapidly.
Thank you. It's an excellent question, because indeed, when one thinks about in research, it went quickly. As a researcher, that's usually never a good thing. In this case, though, I think we have to take a step back, and it wasn't, oh my goodness, COVID is here, let's start an mRNA vaccine. In fact, Moderna had been working and studying and truly getting insightful experience on this mRNA technology, this mRNA platform, for 10 years prior to the pandemic. So when the pandemic hit, we said, our CEO said, our vaccine, our platform, is specifically and uniquely set up to be able to rapidly respond to these emerging threats, viral threats such as the pandemic. So yes, we went quickly from being able to synthesize the vaccine and put it into the human, but that's only because of our experience and the understanding and the actual mRNA platform itself. But that speed did not come at the compromise of quality, nor in terms of the rigor of the experimentation and in the basic sciences, as well as in the clinical setting. When you think about it, this vaccine was evaluated in over 30,000 subjects at the beginning of the pandemic, and then followed through their experience. We're sitting on a body of evidence for safety, tolerability, immunogenicity, efficacy, effectiveness of billions of doses of vaccines that have been vaccine that have been distributed globally and administered.
Great. In terms of how your company does study these things, and I would imagine that Dr. Bennett at Novavax would be the same, is that you are using clinical trials. You're doing clinical research in people. Can you just describe a little bit about what that's all about? You mentioned the phases of these studies, but we want to basically also know that were people of color significantly enough involved in being involved in the research so that we can say that these, we can say with truth and with science and with evidence. I'm not interested in PR statements or commercials, but in truth, that we can say that people of color have been studied, and that we know that even in our population, that these are safe and effective vaccines.
Dr. Tuckson, I can say with complete honesty and truth, the answer is yes. In fact, if you'll permit me a moment to just go back into that phase 3 study. You remember at that time when we were conducting this phase 3, we were in the peak, in the heat of that pandemic, and as we were conducting that phase 3 trial in a target of 30,000 subjects, this was in individuals who would receive either our mRNA COVID vaccine or a placebo at the time. We started to see the enrollment coming in, and we noticed, my goodness, we are not having enough numbers of Black Americans enrolled in the trial. And at that time of the pandemic, what one would have thought, oh my goodness, there is so much urgency here, let's just keep going. In fact, Moderna put a pause. Can you imagine at the peak of a pandemic, when we're evaluating this life-saving novel vaccine, we paused recruitment, worked with their clinical sites to say, we need to increase efforts at the community level, and we'll support you in this, to be able to ensure that we have a representative sample of the population, that every individual, every American can say, I see myself in your clinical data. And that happened. And now we've implemented those lessons. It's not a one and done thing. We've implemented those lessons. We have a whole team of inclusion and diversity to ensure that openness of the communication, and such that our ongoing vaccine development, including those for, we're studying now our vaccine for cytomegalovirus and respiratory syncytial RSV vaccine. We've resulted in an average 40% of our clinical trial participants are of color.
Wow, that's important.
I'm really proud of that.
And Dr. Bennett, I would just imagine that you have the same strenuous attention to this at your company?
Oh, absolutely, yes. It's even risen to the level of the agency, the FDA, asking for companies to tell them the percentage of Black people in their studies. And there is a benchmark you're expected to meet now moving forward. I was wanting to make the point, Dr. Tuxton, I think part of the way to get this to happen is where we put our clinical sites. This country is a demographic wonder. There are places you go to and you have majority Black people. We need to have more clinical sites in those sort of places, and places that are not as diverse. I think part of what my company does is we are strategic when it comes to choosing our clinical sites. We won't just put all the sites in one place that has more of a certain demography, of a certain racial type. We would like to spread that thing out so we can get, like to the point you make, have a good representation so people can feel a sense of comfort and representation when this data comes out. So yes, we're doing the very same things where we are paying attention to those numbers, and it's important that the community knows that this is on the top of our list of Novavax.
And let's make sure that we are clear to our audience that, you know, we can't have it both ways. If we don't participate in clinical trials, then we can't say
we're not there. Yeah,
there hasn't been studied well enough in people of color. It's all of a whole. And again, back to Dr. Griggs, your point about Tuskegee, that's the reason why a lot of people are not participating in clinical trials. And we have to, again, remind people that if we don't have the knowledge, we can't then say that these vaccines or any drug that we're taking is useful in our community. And I think you would agree with that, Eric, I would imagine.
I absolutely would. And you hit on a hard point. The key is education, education, education. Part of the reason that the numbers were up with clinical trials is, you know, Louisiana, I'm in Louisiana, and unfortunately we're 50 right now when it comes to health. And at one point in New Orleans specifically, we were number 3 in the world at the very beginning of this. And it was our governor that went on the news and was the first to declare that 7 out of 10 bodies showing up at the morgue were African American. And the moment that we found that out, we took to the streets, we educated, we beat the drums, and we flattened the curve. Not only that, we modeled to the rest of the country how we can flatten the curve with education, because COVID was a joke in the Black community until that moment.
Wow.
So it's education and frank conversations.
And let me also remind the audience, and this is something that most Black people just did not understand and don't understand. After such a slow start, because they didn't make the vaccine easily available to our communities, we had all of our legitimate concerns about distrust and misinformation, all those issues we had. After we got going, because of 100 Black men and our fraternities and our sororities and our faith-based organizations and our Black medical societies and Black nursing society, all of us came together in a way we've never come together before.
Yeah.
We all worked together. And do you know that our vaccine rates for COVID vaccination, not only did they go way up, they equaled the best results in America. But what's more important, and this is something that is amazing to know.
You take them to church. Take them to church.
Black life survival, Black survival from COVID after the second year was better than white America. Do you understand what I'm saying? We not only caught Leave It to Beaver, but we beat Leave It to Beaver. And Leave It to Beaver had me tennis shoes and a jogging suit, and we were running barefoot with an ankle on our back, and we caught him and we beat him. And that's when it says, when we say that Black lives matter, that means we have to work hard to make sure. Dr. Patel, I want to turn as we start to close out and with also with our panelists about, well, we love this vaccine. It's important. We need to get it. But yeah, you got to be able to get it. And
Right.
so now this year, we don't have the government buying the vaccine anymore for us. And so now we're going to have to go through the private sector processes. Any guidance around what this is all about? Help us to understand what's different this year?
Well, insurance is covering the vaccine this year, and the government is still going to provide the vaccine, but that will be to adults without health insurance and to adults whose insurance does not cover the COVID-19 vaccine. So this is called CDC's Bridge Access Program. You can find information about where to get an updated COVID-19 vaccine at the website www.vaccines.gov.
Wait, you say that one more time? I didn't have my pencil out.
Vaccines.gov. And we are working with state health departments who are distributing the vaccine to local health providers at no cost in their networks. We've got HRSA supported health centers. These are federally supported health centers that are providing the vaccine at no cost. And then we have established new contracts with some of the pharmacies, CVS, Walgreens, eTrue Health, and they can provide the vaccine at no cost. And so CDC is very much committed to ensuring that everyone has access to this vaccine. And for this next year, this bridge program will remain active to ensure that that's the case.
And so, Dr. Mancy, how do we understand companies like yours? Are you going to be able to provide some guidance to help us here on how you're going to try to help make sure that everybody who is eligible and should get it, which is everybody, how they can get it?
Absolutely, Dr. Tuxen. In fact, at the beginning of this year, we announced our commitment to ensuring that anyone who wants a COVID vaccine can get one, without price becoming a barrier. And so we're very pleased and proud to support the Bridge program, the access program that Dr. Patel mentioned, to maintain that broad access for the millions of uninsured Americans. But we're also working with different organizations like Project Hope and associations of free clinics, where we're providing doses to support their immunization efforts to their at-risk populations. And it's in the locations where they often receive their health care. So it goes back to that, what Dr. Griggs, you were mentioning, going back into the community, meeting the patients and people where they're coming and where they're comfortable.
Great. And that really is very important. And by the way, Dr. Griggs, I know you would agree with me that one of the key challenges as the pharmacies, like Walgreens and all those other companies, are becoming the place where people go to get these vaccines and disseminate those through the Bridge program. It's very important, I think we would agree, that community-based organizations and faith-based organizations develop relationships with these pharmacies, and the pharmacies develop these relationships with the community-based and faith-based organizations. Would you agree, Eric, to that?
I absolutely agree. And let me tell you, if you are a faith-based or a community organization and there's a pharmacy school in your region, make friends with the pharmacy school, because everybody, especially in the faith-based community, they love students. They love to feed them. They love to hear what they learn. They believe everything they say, and they want to help. So make friends and reach out to the local pharmacies and pharmacy schools and have them go to their spaces, get out of your comfort zone and go into those community spaces and bring your students, because they'll feed you and they'll believe you.
And as we turn to nearing the end of our time together, but Dr. Patel, there is a very important issue we have to deal with. And that's the issue of masks.
Mm-hmm.
We know that there has, been a lot of different public policy debates around masks and so forth. And recently, a very important study was reported, and quite frankly, I think, and you'll tell me whether I'm right, was misreported from a prominent organization called the Cochrane Institute, which is a British organization that does provide very important evidence-based information for people to make choices and decisions. And they studied this issue of masks. Can you tell us what the controversy has been and what should we take home as the message about whether masks work or whether they don't?
So masks do work. I will say that Cochrane review focused on a certain type of study design. They're called randomized control trials, which are, big, onerous studies to do. And because they limited their review to those studies, they made a determination based on those studies that was not entirely correct. If you consider all the other studies that have been done, particularly during the pandemic for SARS-CoV-2, many showed that masks can protect you and can prevent transmission of SARS-CoV-2. It's really important to wear them properly. They have to fit. You have to wear them over your nose, not on your chin. And it's really important to choose a good mask. A surgical mask is a great option, for example. I think what we really do need to take away about masking is it doesn't seem like there's much of an appetite for it. But I would urge you to consider masking on public transportation. We recommend it. There are no mandates for wearing masks, but if you're in crowded places like planes and trains and airports, it makes sense to wear a mask because you don't know what exposure you may have. And particularly if you have someone who's vulnerable to severe COVID at home, for example, or in your community, wearing a mask could help protect them from getting sick, even though you may not get sick if you're infected.
So again, if you're immunocompromised, if you're older and a senior, you want to probably be precautious and take the precaution and wear the mask. And to summarize that stuff with that report, what it really does is that they could not prove that wearing masks will have a major effect across the entire population, because they couldn't do it because it's impossible to study it. Do you wear your mask properly? How often did you wear it? When did you wear it? It was impossible. But what they did not say, and this is the take home, what they did not say is that masks do not work to prevent the virus from spreading from me to you. That is what you need to know. That was not what the study was designed to do. And so if you ever hear anybody walking around say, well, there's a study that proved that masks don't work, that is not the case. There have been retractions of that, clarifications. But at the end of the day, if you wear it and you wear it properly, it will work. In 10 seconds, I'm going to go around the table, starting with Dr. Bennett, then Griggs, then Dr. Mancy, and then Dr. Patel. 10 seconds. What's the one thing you said that's the most important, or the one thing you didn't say that you wish you had?
You have options now to take a vaccine. There is no reason not to get a vaccine in the fall campaign.
Thank you. Eric.
Ask the hard questions, find the students, feed the students, listen to the students. It'll save your life.
Dr. Mancy.
The burden of COVID is real. It's here. The vaccines are safe and effective. And if you have a question, ask your healthcare provider, a trusted community resource.
Dr. Patel.
You have the power to protect yourself and your loved ones and your community. So I say do it. We have all the tools: vaccines, masks, hand washing, physical distancing, isolating. There's so many things that you can do to protect yourself and your loved ones.
Well, you have been a terrific, terrific panel. I think that as we look to the audience, we know that you have questions. It's good to have questions. Seek answers. Seek answers from reputable places. I will say that if you ask most health professionals, where do they get their evidence, fact-based information? We go to the CDC website. Regardless of any nonsense that you hear or confusion about the FDA, the one thing you can rely on is that the scientists at the FDA, take all the politics out, take all the social tweeting out of it. The scientists at the FDA know what they're doing. It is a very organized process. And go to the CDC website if you have questions. Of course, as Dr. Mancy said, go to your local health professional, ask questions. It's okay. But above all, please do not listen to Pookie on the internet. That's what you don't want to do. Be clear about who you listen to, because let's face it, ladies and gentlemen, it's our lives that are at stake. We're trying to survive. I want to thank all of our panelists. I want to particularly thank BIO for sponsoring this, the world's largest biotech trade association, the field where breakthroughs begin. And I also want to thank Ellis Dean and the team at blackdoctor.org for another great job Stay tuned. We'll see you again for the next show. Bye-bye.